Hello, I'm Radi Masri of the American Board of Prosthodontics. The board is happy to release a scenario that will give you an example of a real-life test. As you know, there is a Section A, which is a written exam, Sections B and D, which incorporates your clinical presentations, and Section C, which is the scenario exam. You can opt to do the scenario with any two parts of Section B. However, you cannot take both Sections C and D to satisfy requirements of certification by the American Board of Prosthodontics. Should you opt to do the scenario, this video will give you an example of one scenario exam in real time. We enlisted the help of Dr. Scott Hollis for this example to be a candidate. Mind you, he is already a diplomate of the American Board of Prosthodontics. The scenario exam is a 1-hour exam, where 3 different scenarios are presented of various topics. These topics will cover a wide range, including fixed prosthodontics, complete dentures, removable dentures, implant dentistry, management of emergencies, prosthodontic complications, and so on, and any combinations of these topics. The exam is narrated, meaning that all the questions will be read to you, and they will be also projected on a screen that you can see clearly. The scenario exam is broken into 3 scenarios that are 20 minutes each. Each 20-minute scenario is given by a team of 2 board examiners. The examining team will be different for each 20-minute exam. In total, you will be examined by 3 different examining teams. Each 20-minute scenario is broken down into 4 main topic areas: diagnosis and data gathering, that's 5 minutes, treatment planning, 5 minutes, treatment, 5 minutes, and outcome and prognosis, 5 minutes. The examiners will grade you on each of these areas for each scenario, independent of each other. The grading sheets are collected immediately after the exam and sent for sophisticated statistical analysis that will analyze the performance of each candidate relative to the scenario difficulty. It takes approximately 4 weeks for the data to be analyzed and sent back to the boards for review. All scenarios are narrated using a pre-recorded script that has been reviewed by the board, such that all examinations are delivered in the same way. During the examination, the candidate is not allowed to ask questions, and the examiners will not answer any questions. The examiners in the room will only grade your responses to the narrated questions. It is important that you answer the questions in a timely fashion, as all questions are timed. Make sure you talk and continue to talk. You do not lose points for wrong answers. You will be provided a notepad and a pen to write notes. However, you cannot take these notes with you when the exam is completed. During the scenario, you are graded against the other candidates. If after your exam you share information related to the examination, such as content or answers, you may be putting yourself at a disadvantage. This is because each individual is graded according to examination difficulty and examiner difficulty. Sharing information with others may alter these metrics and lower your final grade compared to others. So today, we will have Dr. Scott Hollis giving the answers. I did ask him to pause occasionally and to intentionally provide wrong answers in some instances. Dr. David Cagna will assist me in conducting this example scenario.
Hello, Dr. Hollis. You are here today to challenge Part C, the scenario exam of the American Board of Prosthodontics Certification Examination. This exam is composed of 4 sections: diagnosis, treatment planning, treatment, and prognosis and outcomes. Each section will last 5 minutes. Please do not ask us any questions, as we will not be able to answer the questions during the exam. You can use the notepad in front of you to take notes during the exam, but we have to collect those notes before you leave today. Are you ready to begin?
I am. This 34-year-old male patient presented with a chief complaint. My teeth look too small and have jagged edges. I would like to have whiter teeth with more uniform color. Describe the possible etiologic factors responsible for tooth structure loss in this patient.
From looking at the photographs, I see a generalized wear pattern in this patient. Potentially could be from parafunctional habits that could be diurnal or nocturnal. Um, from looking at the posterior teeth, the occlusal surfaces, I'm seeing what looks like maybe some cupping, which might lend itself to an erosive component to this wear that the patient is having. Seeing generalized wear like this tells me that the patient is probably in group function. The patient may not have been in group function all their life. They may have at one point in time had mutually protected occlusion, but at this point they do not. I'm seeing some class 5 restorations, possibly could have been from some type of abfraction due to the stresses on the teeth, or possibly some type of combination.
How would you assess occlusal vertical dimension?
In this patient, I would probably look at maybe using phonetics and aesthetics to look at vertical dimension. Possibly I'm thinking maybe you could potentially use the same method that we use for edentulous patients, using pleasure points to measure rest space to see if there's an excessive amount of resting position in this patient.
Identify aesthetic deficiencies and strategies to correct them.
What I'm seeing is obviously from the wear, we have some shorter teeth. The patient displays a diastema between the two anterior maxillary teeth. That could be an aesthetic deficiency. This coloration of the teeth, having previous metallic restorations that have leached into the tooth and caused a change in color. Some of the strategies might be to gain more tooth structure, might be crown lengthening of some type, whether it's aesthetic or functional. Looking at orthodontics to move teeth that are malaligned and maybe to close off a diastema, or to level the CEJs or the gingival complex. Obviously, we could restore the teeth in a manner to correct the color of the teeth. That would probably be with full coverage restorations.
Describe options to test if patient can tolerate changes in OVD and advantages and disadvantages for each.
Describe options to test the patient's tolerate changes. Probably one of the easiest ways to test it that's not too invasive would be to use some type of splint therapy that would increase the vertical dimension to something close to desirable for us. Probably disadvantages or advantages of that would be it's low cost, it's non-invasive, it's easy to fabricate. Some of the disadvantages might be compliance with the patient, whether they could function with it. Those are always things to think about and sometimes problems. There's another method, I believe Coyce has a method of creating occlusal veneers that can be bonded to the teeth that could open the vertical dimension, and the advantages of that is the patient would function more like having natural teeth, but it's very time intensive. Probably, you're going to have to charge the patient for it, so it's going to be more expensive.
If periodontal surgery is performed for this patient, what are the goals as related to function and aesthetics?
Function and aesthetics. Obviously, we want to, with periodontal surgery, in this case, probably crown lengthening of some type, to expose more tooth structure, to gain a better ratio between width and length of the teeth, give us more retention and resistance form for our preparations. With crown lengthening, it would probably help out with
what
crown
aesthetic
contours.
factors influence a decision to perform crown lengthening surgery, and how would you ensure proper execution?
Aesthetic factors. Obviously, with crown lengthening, you're changing the gingival height, so you want to make sure that whatever method you use to a wax up or something like that, a mock-up that you would provide your surgeon would allow for a good crown ratio length to width. If it's functional crown lengthening, you might have a problem with black triangles because you may lose papilla height. If you've got triangular shaped teeth with tapering roots, again, you could run into aesthetic issues of black triangles and losing your papilla height. From my wax up, I would create, as far as proper execution, I would create a stent that would allow my surgeon to see where I would like the incisal edge and where I would like the new gingival margin to be placed.
What are the factors of an ideal tooth preparation for a full coverage restoration?
I would probably cite Charlie Goodacre to answer this question. Dr. Goodacre suggests minimum prep heights of 3 millimeters for the anterior teeth and 4 millimeters for the posterior teeth. I believe he suggested a total occlusal convergence of 5 to 10 degrees. Um, um, I can see in the photographs here that there are some additional retentive and resistance features that are placed in some of the molars, some grooves and boxes. Um, um, just making sure that you have good retention and resistance. Like I said, there's in the photographs, you can see that on some of the molars that they have, there must be shorter preparation, so they've included some retentive features.
What techniques are available to retract soft tissues and achieve hemostasis during impression making?
Probably the most common method is using retraction cord. Some cords are already impregnated with some type of hemostatic agent. Others are not. You could use an astringent material to impregnate a non-impregnated cord, or there are some astringents that can actually be scrubbed into the tissue. I think quite a few practitioners nowadays are using lasers to trough and retract tissue. Some are still using electrosurges. That's still fairly common. I've used both of those in my training. As well as different types of retraction methods. Yeah.
What adverse reactions can happen when you retract soft tissues, and how would you avoid them?
Probably one of the things that we're concerned about most with retraction is being too aggressive and causing potential tissue recession, especially in the aesthetic zone. I mean, I would use the correct size retraction cord. Using a technique that is, and I usually use a 2-cord technique. Sometimes a single cord technique if the margins or the finish lines are supragingival. As far as to how would I avoid them, additionally, as far as the type of astringent that I would use and the cord that I would use, the length of time that it's left in the sulcus, I would make sure that it's not too long.
treatment consisted of crown lengthening and metal ceramic restorations on all teeth except for the second molars, which were restored with cast gold crowns. What aesthetic goals were achieved in this treatment?
Um, Obviously, the color was corrected. It's more of a uniform color now. Um, the occlusal plane, in this case, was corrected. Um, uh, as far as tooth proportions, we talked about that. I talked about that previously with crown lengthening. I think I answered that in one of the previous questions. Um, uh, I would say gingival levels are in their proper position relative to the teeth. Um, Apparently, the patient wanted to have the diastema closed, so the diastema was closed with the final restorations.
What can be done to reduce the risk of porcelain fracture?
Um, After treatment is completed, I would make this patient a splint that they would probably wear at night, um, basically for the rest of their life to help protect any type of nocturnal parafunctional habits they may have. Obviously, they may still brux, so we have to protect the porcelain that way. Um, it looks like in this case, just from the arrangement of the teeth, I would imagine that they were able to regain mutually protected occlusion. I can't tell honestly from it, but I would imagine they did. Um,
What are the advantages and disadvantages of gold crowns?
Gold crowns. Um, they're thought to be very compatible in the oral environment. Um, they require less preparation, less tooth preparation. Um, uh, the material itself, gold, has a really good um, wear factor. It doesn't tend to wear the opposing teeth. Um, I know in my practice, I've used gold a lot. Uh, it's it's an easy material to deal with as far as polishing. Um,
That concludes this portion of the Section C examination. Dr. Hollis, please leave any notes that you may have taken on the tabletop in front of you and proceed to the next portion of this examination. Thank you very much.